Welcome, everybody. My name is Anna Lepevic. I'm here with a special guest today, Dr. Heather Florescue, who is one of our medical advisors at Push. We're so happy to have you. Do you want to give yourself a quick intro so everyone knows who they're speaking with today?
Sure, I'm sure many of you already know me. I'm Dr. Heather Florescue. I am an OBGYN in Rochester, New York. I am in a private practice called Women's Gynecology and Childbirth Associates, and my passion is caring for people who've lost babies and doing grief support and counseling, and in the last 4.5 years, working on the prevention piece.
If you don't recognize, we are trying out a new platform here, so I'm playing with it while Heather's speaking. But thank you so much for being with us today,
Of
Heather. We really
course.
appreciate you and all that you do for the community of loss. We wanted to start this conversation, of course, just kind of setting ourselves centering on the families of loss, as I am myself. You can see here my son's photograph. My son Owen Nathaniel would be 8 this year if he were still with us, and I do this work in his memory, which all of us at Push are volunteers, leading what we can to kind of put more emphasis on stillbirth, because as we see a lot of talk right now, maternal care, the crisis that is existing in the United States, stillbirth gets left out of the conversation quite a bit. And so our organization, Push for Empowered Pregnancy, is trying just to make sure that we keep talking about the babies as well as the mothers. And of course, there is a very close connection and outcomes of stillbirth. Also, if you experience a stillbirth, you're more likely to have a risk for maternal mortality as well as morbidity issues. So we just wanted to, welcome everyone into the space, knowing that a lot of us are here because of loss already. And, we see you and we are you, and we're so sorry for your loss. And I know, Dr. Heather, you wanted to say something specifically too on that.
Yeah, I think, the goal for today was we're going to talk a little bit about empowered pregnancy and how to feel empowered. And I just wanted to make sure that for any lost families that are listening to this, or especially parents, that if you didn't get an instinct that something wasn't right with your health or your baby, that is not your fault. Not every stillbirth is going to be preceded by an instinct that something is wrong. But one of the goals that we want to do today, along with any other questions you guys had, was to, if you do have that instincts, give you all the tools to feel empowered to advocate for that care.
Absolutely. And so let's just start off with, what are your top kind of speaking points with new moms? How do you have this conversation about awareness of movement, or how do you go about it? Because I know a lot of providers are worried that they're going to scare moms about talking about stillbirth in itself. So how do you go about doing this with your clients now?
I think it's actually become more easy in the last few years to approach this conversation. I think some of that is Rochester is a very close-knit community. So I think some of the work that we've done, I don't have any actual documentation or studies saying this, but I think Rochester has become one of the best places if you're going to have this terrible thing happen to you. We just have a lovely community. So I think as a result of it, people are talking about it more, and patients are actually coming to me and saying that they know somebody who had a stillbirth. And so I think the awareness is helping. But that being said, every pregnant person in our practice at 20 to 24 weeks, we shoot for around then, to talk about the importance of fetal movement, give them fetal movement education cards, and really talk about that they're going to get to know their babies, that usually the pattern is going to form somewhere between 26 to 28 weeks, and then stressing that they're never bothering us, and saying to them that they always need to trust their instincts, and showing them that on the cards it says trust your instincts and call your provider. There's nothing about juice or crackers or talk to your mother, your sister, your cousin. It really is, you're worried about you or your baby, give a call. And I tell people to keep it on the fridge. And I always say to people, this is not just about fetal movement. If you have a headache or you're feeling unwell, this is also something that you always want to trust. As we get closer to the end, I think one of the biggest mantras that we always try to give is, you're never bothering us. You're never being in trouble. This is what we want you to do. I'll tell people that I'm not psychic. My partners aren't psychic. We only know if you're worried if you give us a call. So really just empowering that that's what we're here for, and that, they're never bothering us.
Yeah, I love that you have that conversation. So, in my experience, it was not such a big discussion. I was just given a pamphlet at the time I was pregnant, apparently, and that was thrown in with the vitamins and supposed to be one of the many things that mom might just supposed to know. I don't know. But what I love of what you said is it's just a bigger conversation about it. And it's just like knowing you're normal, knowing your baby's movements are like. So you usually do kick counting around 26, 28 weeks when there is a pattern of movement. So you can get to know your baby and every day you want to do this around the same time. And if you like, you can use an app like Count the Kicks, which is free, which we recommend as well. That way you have this ongoing notification on your phone too to remind you, because we all get busy and you want to make sure you sit down and just give yourself that time to feel your baby so that you're not ever surprised by the fact that, like, well, I don't really know when the last time my baby was moving. Not quite sure if it's been the same or not, because your doctor might ask you, they might not, but you need to be aware that that's kind of the baby's way of communicating with you, obviously, through movement. And you are the most familiar with that. Your doctor won't have a clue, really. They're just going to run their tests that they do normally at visits. And if that looks good, they're going to send you home. So you have to be the one that really advocates for yourself and your baby if you feel some sort of change. What other questions do you normally get from people in the community? I know you're very entrenched now with the stillbirth community. So what other things do you hear that they maybe didn't get in their care? I know myself, that was one major thing. We didn't have a big conversation about fetal movement. Was there anything else that you're doing differently?
I don't know that I can say necessarily in our community that often when I hear from transfers is more the language that was used after they lost the baby. So less the like, um, it's a lot of that somebody, it may not even be like a healthcare provider or nurse, but just the language people used when they kind of, silver linings and, kind of platitudes and stuff like that. So I think that's a big aspect of what we're working on. Um, I think really it's just feeling like they were distant from their providers. I think I've been doing this work in our community for 4 years and 4.5 years now. And I think we, as a community, are doing a much better job with educating our patients. And I think when our patients are calling, they're getting much better assessments when they go to the hospital. So I think we really have made strides. I think the other huge stride that I have kind of helped make with the loss community is really not just looking at the doctors and the nurses as the people who can do empowering. And I think in the last year, especially as COVID kind of run down, we've been getting our chiropractors involved and our physical therapists and our doulas. And I think that has been such a key piece to this, because you don't know who the person in the OB community is going to be that hears somebody say, I'm worried about my baby's movement. It may be the chiropractor who is seeing the patient for hip and back pain who says, oh, by the way, my baby isn't moving as much. And that can be a point of entry to recommending a phone call.
I love that, and I agree. We always advocate for having someone else with you if possible for your appointments too, because it can get really stressful and you might forget questions you might want to ask. I used to do it always in my notes on my phone, write things down that I was feeling throughout the day or something I might want to remember, and don't leave before you have all your questions answered or if you communicated fully how you're feeling. Because it's very easy, I think, for a patient, especially, in this situation where you feel like the provider knows more than you. And we always say, you know your body and your baby best. So we again recommend that you write things down. Make sure if you can get a doula to come alongside you. I know that there's starting to be Medicaid payments and things like that. So there might be options for you with that, or just even a family member if it's not your partner, just to sit there with you, make sure you heard right, they heard right. You guys can communicate like, oh no, we didn't get to say this, call again. Um, I do have some questions that were submitted prior, so we're just going to honor that and send a question over to you here. This is very specific. So some of the causes of stillbirth that we know include cord trauma or accidents. I don't like to call it an accident, but the cords can compress. So this person was asking, do babies compress their cords off and on Is it normal, like, or how does it become a problem if it's staying compressed too long? Are you familiar with the science behind that?
So I don't think we actually know from talking to pathologists. So it's important to know that only about 20% of term stillbirths are actually cord accidents. And from talking to especially like Dr. Kleinman, it sounds like these are truly the baby's okay 1 minute, then unfortunately they're not doing well the next. So it can be any point of the cord. So things that may make it more likely to have like a cord accident would be if it's overcoiled or undercoiled, stuff like that. We really don't think cords around the neck are a risk factor for stillbirth. And one of the really important things when people experience this loss is to not automatically come, and I know this is, Anna thinks a lot about this, to a diagnosis without having all the information.
Hmm.
Because it's so critical that we don't say that the cord accident was necessarily the cause until we have a placental pathologist look at the placenta, until we get all the information back, because we want to make sure that we're giving our grieving families as much information as we can about what may have led to this tragedy.
Right. Yeah, that was actually our loss caused by cord compressions, which we didn't know was happening for days prior. So I think what it has helped me in knowing that information is thinking more about the cord and like the fact that it's even in potential, the cause of a stillbirth. Asking some questions, maybe. I don't know how many providers can scan the cord or not, but that might be a MFM issue. But also more so being aware with the movement again. We can go back to that, I think, because imagine like you're a scuba diver and that's your tube and that's how you're getting your oxygen and it's getting compressed. You might kick a little differently, or you might, so we've also mentioned it's not just a decrease in movement, it could be increase and it like a frantic kind of really like, whoa, this baby's acting really different right now. You want to speak up about that. That could be a way to, have your baby checked out and hopefully, some interventions take place. Just kind of along that line, what do you do if you feel like the mommy and, she's communicating like there's difference here and what do you do? What's your first steps to react to
Yeah.
that?
So we incorporated in August of 2019 the Saving Babies' Lives protocol from the UK. And so what we really standardized was the first piece we covered was that fetal movement education. But the second thing that we standardized is our response to the concern. So anywhere in healthcare, because there is no clear guidelines of what to do, someone might call and say, I'm worried about my baby. And you don't know who's actually answering the phone and saying, oh, you don't have anything to worry about. That's normal. Or they're running out of room or they're sleeping or all the myths that we talk about. And so when they call our practice, it goes directly to the nurse. The nurse opens the protocol, and then we always bring the patient in, even if they're very early and, they're 19, 20 weeks and it's their third baby and they didn't feel the baby and they're worried. We can always do that DOP tone. And the nice thing about those early listen-ins is we can say you did the right thing, and please let us know if this happens again. So kind of really reiterating that. After we get the evaluation, which is based on kind of gestational age, but does for the most part include looking at the ultrasound for growth and fluid, we ask the patient the really key piece, which is, are you reassured? And I found in the last 4.5 years, I feel like it's really predictive. And there's, as I said, this is not something, unfortunately, we all know this is understudied. But I feel like when those patients say to us, no, I'm not reassured, that's where, we look at the gestational age and say, is this in the range where we can consider induction? The last time we had this happen, we sent the patient over for more monitoring, and then the baby kind of told its story, and we had a healthy baby. So you need to kind of say, you know what, maybe the NST and the ultrasound is not enough. Maybe this is a baby that we need to monitor for 24 hours or whatever we need to do to kind of see why this mother is not feeling reassured. And I've had patients who are, I had a patient several years ago who was not reassured. She was like 37.5 weeks, and your kind of hands are tied if the evaluation looks okay. So I said, well, let's just keep you for some continuous monitoring. And then around 2 a.m, her baby kind of went back to doing totally normal movements. She said, I am reassured. I'd like to go home. And then she went home and had a healthy baby, 2 weeks later. So I think it's just making sure the patient feels like we're totally actively listening. And I think the protocol really helps with that.
Hmm. And that's something I think that needs to be done everywhere. So Dr. Florescue, you have a job to do. Talk to all your friends. Because also I'm seeing here in the comments on Instagram that people are saying, even the front desk type people, or if you call into
Mhm.
an ER, like I called in, they can give you conflicting advice. Like
Oh,
mine told
100%.
me, stay home and eat a meal and do some more kick counting for 2 more hours. It's like all these extra delays could have cost, it
Of
might have been
course.
the reason, my son didn't make it because of the additional delay time. Whereas I already had a feeling, and I think that's what you were alluding to, is kind of a maternal instinct feeling like something's a little off, the baby feels different. So trust yourself, your gut instinct. And if you don't have that, I mean, it's not like a science, like she was saying, we don't have proof that this is a thing, but like I think a lot of us anecdotally, we felt like something was wrong. We had kind of an alarm bell going off. And then, just no one actually telling us about fetal movement change was a problem for a lot of us, or people questioning it, like telling you, oh, that's normal at the end of pregnancy, things like that happen, like the
Mhm.
baby might slow down, which is false. You shouldn't see like a decline in movement at the end for whatever reason. People think that still. What other
Right.
myths have you heard that you just want to dispel really quickly for our audience?
Well, I think they're running out of room one. So, it makes absolutely no sense that the baby was moving fine on Tuesday and not moving on Wednesday. It makes no logical sense. Why would the baby have all the room in the world to be active on Tuesday and then on Wednesday they suddenly are running out of space? There was a prospective study that was done that really showed that the vast majority of babies actually are more active and more strong in their movements as they get towards their delivery, not less. So one of the things that always worries me so much is family thinks they're doing the right thing. Please, please, please do not listen to your family. Just because they had babies doesn't mean they're OBGYNs or doulas or certified nurse midwives or nurses who do obstetrics. So you really, I always think about the tragedies that happen where family members who love my patients dearly give them the wrong advice, and the advice results in them not getting care. And I know that must sit on the heart so much of the family that does that. So they're getting care for a reason. Anytime somebody you love is saying that they're worried about themselves or their baby, just say, call your provider. It's very simple. They're not being overly anxious. I really don't think that's a thing. And I think negating that is just something that you're going to have to live with the rest of your life, and so will they. So, anybody out there who is hearing this that hasn't heard all this stuff before, please, if somebody expresses concern, just tell them to call their provider.
Hmm. So there's so many comments on Instagram. I can barely keep up, but there's some good questions here. So I'm going to try to give you another one. So, of course, the anterior placenta makes it harder to
Mhm.
feel baby's movement because the placenta is on the outer part of your belly. So if the kicks, I don't know, it might change how it's felt. But this mother was saying that, it was her first pregnancy with the anterior placenta. So she didn't really feel the movement, so there's no way for her to know physically, if there it was anything wrong. Um, and so she was hospitalized shortly before her son died, but all they did was really check the heartbeat with the Doppler and then discharged her, and then he passed away soon after. So I think that highlights an important point. First of all, just for any mother, if you're home and you feel something's off, don't bring out the home Doppler. Like we all say, that's just for fun. If you want to hear, around after, the baby has a heartbeat, you just want to hear the baby heartbeat, that's fine. But like, don't use it as telling you if your baby's okay. Because first of all, you may not be using it properly if you're, a regular mother. But even for providers, I think that's an important point. Like if your patient comes in, you should do more than just check the heartbeat, correct?
Yes. And so there's 500-page books on the art of reading a baby's heart rate, just like an EKG kind of thing, right? And so you wouldn't read an EKG based on one beat. You wouldn't do that based on a Doppler. And there are babies who can need immediate delivery. We call them category 3 tracings. And a couple of those category 3 tracings, the heart rate actually might be 140s or 150s or 130s. So a normal beat, but how it looks over the course of watching it, which we would do with an external monitor, it's clear this baby needs immediate delivery. So it is not reassuring when you are worried about your baby's movements to hear a heartbeat that is 140s, because baby could be doing one of these things. You may not be catching the whole picture. So just like Anna said, if you feel like your baby's moving like crazy and you want to hear their heartbeat, by all means, listen to your baby's heartbeat, but it is not a tool for when you're worried.
No, and then along those lines, so we have our measure the placenta ladies here chiming in on the chat. So we just want to mention placentas for a minute because I would be remiss. Placentas are one of the leading causes of stillbirth, issues with the placenta. So what do you do different in your practice, and what would you suggest to providers who are a little bit maybe feeling weary of new technology, such as what Measure Placenta wants to have done, measuring through a EPV, it's called, just to kind of open this conversation. I know we don't have enough research, unfortunately, in this country on a lot of things, including the placenta, but there is some investment now on that. What do you think patients should ask for in regards to placenta? Like, I mean, I never thought to ask a single question. I'll be honest with you. I didn't know that there was any concerns with the placenta. Like,
Yeah, yeah,
comes
that's a
along with
hard.
your baby. It grows and it, provides the food,
Yeah,
and that's about it. And that's my level of, knowledge prior to now. Obviously, after stillbirth, I've learned a lot.
it's a hard one. I think so. Obviously, we always look at the placenta. We always look to make sure it's in the right location. We always look to make sure that the placental cord insertion is appropriate. So that's something that should be done when you do an anatomic ultrasound, because you can see something called like a Villamentis cord insertion or a marginal cord insertion. So those are things that we like routinely look at. And we also look routinely to make sure that the membranes are coming out normally from the placenta. So sometimes they come out from the middle of the placenta, which obviously it's called circumvallate insertion, and that can impact the growth of the baby. So those are all things that are done and should be done every single time you have an anatomic scan at that 20-week mark. What I do in our practice is actually less formal than simply just kind of putting in the EPV because we're still waiting on those prospective studies. When we look at the placenta, I'll do a measurement and just make sure it's okay. And I will tell you 99.9% of them are totally okay. So, if for some reason you see one on the smaller side, then you can do more frequent growth and everything. But I'm hoping our prospective studies are really going to make this a tool that all of your providers will feel very comfortable using. I thought of an analogy for this because I very much believe that the placenta is so incredibly important and that measurements are important, and why the prospective study thing is kind of a hang up for OBGYNs because I think it's important to kind of go through that. So I was actually explaining this to a patient recently. There's something called an echogenic cardiac focus. And what it is at 20 weeks, the heart has a very bright spot on it. And large studies of following this have shown that a baby, when you see this, we see it all the time, that it is not a structural issue with the heart, and that the only thing you need to do to make sure that baby is okay is to see if the parent is interested in checking for things like Down syndrome, trisomy 13 and 18. So offering genetic counseling. If when we saw that, we said, we don't really know what this means, it would be much harder to be able to reassure patients. So I'm hoping very soon we can be able to make EPV totally standard of care by these prospective studies being done, where we can say, your placenta looks really small and here is the evidence and here's the plan going forward. So we can make sure that we're not giving patients information that we don't have data points on. So I kind of use it now as a way to just check on every single baby that I read a scan on and just make sure we're not missing anything.
It's interesting to me scientifically, really, to see it. Like, I think for you as a scientist, I'm sure it's like, oh, let's just double check that everything's great looking in there. Like, you already see everything else. And, our testing, like even NST that people do has its flaws, and it's, only really a snapshot of how your baby's doing
Yeah.
in that moment, which people don't understand. So I want all the parents on right now live watching us everywhere you are to realize that if you get that NST and you're still not reassured, that's what Dr. Florescue is talking about. Keep speaking up for yourself and your baby and say, that's great that you're reassured, but I'm not
Yeah.
fully feeling the same. Like my baby's not the same, or I still feel off. Asked to stay, overnight if possible, to be monitored, because things can happen very quickly. And sometimes the NST is not monitoring your baby when they're in the wrong position. Like, let's say that is a cord compression, they can roll off the cord and be fine on the NST for a little while and look like, okay, they're reasonable, they're looking okay. they could send you home, but you're still like, in the next few minutes, you're like, no, this isn't right.
Make
What's
sure,
NSC stand for? Someone's asking me and I'm going to get it
yeah,
wrong.
non-stress test. So
Non-stress test. Make sure your
non-stress,
baby's not stressed. I'm stressed
yeah,
right now.
yeah.
That's why I turn red because I have a trauma response to my stillbirth. So anyway, body keeps the score, unfortunately.
Yes, body always keeps a score. There is a stress test, which we don't do as a formal test as much. It's actually a very accurate way to assess babies is doing Pitocin and actually stimulate contractions and see how baby tolerates. We just don't use that as much because often if you're thinking that you're that worried about a baby, you probably should be having a baby. I think comes up a decent amount. There are other ways that you can look into placental health. So normal fluid, whether it's, high fluid and low fluid, can suggest placental health issues, which is why we watch that more closely. The other thing is asking your doctor to check if you did a first trimester screen. Only if you did that screening test, there's something called a PAPA. It's PAPPA. And if that is low, that is a marker for potential stillbirth. And so we always make sure to know that when we review them in our practice and make sure that patient's getting follow up.
Mm.
Another test that follows up on that is called an alpha fetal protein. That's usually done between 16 and 18 weeks. That is a marker for spina bifida, as well as omphalocele and gastroschisis, which is when the front doesn't close. That's usually very high in those conditions. But if the baby doesn't have those conditions and that level is high, that is another marker of potential issues with stillbirth and growth of the baby. And that would be something you want to watch closely. So we try to always counsel people about this test, and I always tell people the vast majority of the AFPs are normal. But for lost parents after pregnancy after loss, I always do it because it's another normal box to check. And for patients who are not, I always say to them, this may really make us do things that wouldn't be indicated if we didn't have this. So I get one positive every year, but I will tell you, I'm so glad we watch those babies more closely because something always creeps up.
Hmm. Oh gosh, the comments are really heartbreaking in here, but there's so many that were told, either they mentioned that the movement was different and they were told everything looked fine. And then within, days to weeks, the baby passed. So, if that doesn't tell new pregnant woman anything, I hope, beside the research, these stories for me really highlight the need to keep pushing for yourself and your baby. And again, we don't blame any of ourselves for our loss because we didn't know what we know now. And myself included, this was 8 years ago, but no one spoke to me about stillbirth or how to prevent it or the fetal movement, importance of that. Um, and yeah, the issue with the NST, like I'm seeing here, someone had one done and he was gone not even a week later. So again, that's just predictive of how baby is right now in that moment of time. And I was told sometimes up to an hour, but I don't see that really being the case. I mean,
No, we kind of go the 24, maybe 48-hour kind of thing. Uh,
um,
but
but
not, yeah, it's not. I have patients who get an NST that looks great and they're reassured, and then 2 days later they're not. So
mhm,
it really is something that, every time you see somebody in triage or we see somebody for this, we say, you did the right thing and you're letting us know if this happens again. So, and you have to be very, very clear with patients that this is a one-time look at the baby, and make sure you advocate to check at the very least the fluid. We can't always do growth scans sometimes if you're a triage at midnight or 1 in the morning, but make sure somebody's checking your fluid level because I will tell you the patients I see sometimes who are not reassured, especially as they get past like their due date, often it's that the fluid is low. So make sure somebody's
mm,
checking on that.
yeah, definitely. I didn't go home with my pregnancy after loss. Once they told me it was a low fluid issue, I was like, nope, I'm staying until baby's here. So I was kept on a monitor for the last week. And, even though they got me to normal, I was like, I'm not going to drive an hour home when you're telling me there's something going on. Like there's a reason this is happening, right? So I
Yeah.
decided I'm staying here no matter what and push for it. And my doctor made it happen because,
Yeah.
there's always an insurance issue and things like that. But if you keep pressing on it, um,
Excuse
maternal anxiety actually has been used as somewhat of a
me.
reason to induce earlier too now. So if
Mhm.
you have severe concerns, make sure your provider knows, like, I don't necessarily need to go to full term. If you see like my baby's looking healthy, everything's good. Like if you're really scared at the end of especially a pregnancy after loss
Yeah.
situation, there's very good reason to
Yeah.
just go ahead and deliver a little bit early if
Yeah.
your baby's ready.
Pregnancy after loss, we do have some leeway. Really, when you haven't had the prior loss, often we are stuck by that 39-week thing. But if, let's say, you've had multiple times, you've come in for decreased fetal movement, we've done multiple evaluations, often we can talk to a high risk OB and just say the extreme anxiety and all these things. And a lot of it is then at that point. So, if I have a patient who's 38 weeks and 2 days, and this is the third or fourth time, a high risk OB will often say it's very reasonable to do. And you just have to counsel the patient about the risks prior to 39 weeks.
Mhm. I'm gonna give you one more question from our Instagram comments prior, just so we get it in. If you are 5 centimeters dilated or around there, should you be sent to L&D or at least monitored more? Like, what is the suggestion if you're around 5 centimeters? 'Cause
I think that's a completely patient specific thing.
yeah,
Um,
talk
there
to
are,
your doctor, definitely.
yeah,
If
talk
you're
to your doc.
feeling things.
Yeah, it's so hard without knowing all the context and all
Mhm.
so that's a very patient specific thing. I have many patients who walk around that dilated, so it just depends how they're feeling about their baby and all the other aspects of their care. So yeah, there's definitely no hard and fast rule on that.
Well, we are at our end of our time, but I just want us to end kind of how we started. We actually have a question here, so I want to acknowledge again the lost community. How do you coach a lost mama who blames themselves for not going sooner?
Mm.
Felt something was off, but baby moved a little. So at the time, they thought that was okay. And hindsight brings them so much self blame. And I see Marnie as well from our organization saying everyone, unfortunately, a lot of us feel the same way about that. What do you say to your lost parents after something happens? Obviously, we all do our best. We would fight tooth and nail to save our baby, and I think that's the really hard part is we didn't know anything was wrong. In my case, I think a lot of it had to do with awareness of stillbirth, like no one telling me you could still lose your baby in the third trimester. Fortunately, I was reassured so much to the point that I think that kind of made you not think those little bells were anything, like how she's mentioning. Maybe she felt a little change, but again, people telling you like it's okay, it's normal, or you never really imagining that it can go so badly, like at the end, when you were healthy all along. Like I had the textbook. They use
Yeah.
those words, I think, with every normal pregnancy, and I hope you don't use them anymore, Dr. Florescue. But when they tell you it's a textbook pregnancy, that automatically makes you just like back off any of your concerns. You start to feel like, well, I must be crazy, or, they're seeing it, everything's perfect on their end. I can calm down now, so you get kind of a false reassurance. So, what do you normally try to say to your patients after loss?
Oh, well, so to the kind of textbook, I don't think I've ever used that word.
Thank you.
I
Like, just to confirm, that's a horrible way to put it
Yeah,
because
I don't ever use
no
that word.
pregnancy should be
Yeah.
by any book. They're all different,
I
right?
I also people say to me, am I now considered high risk? And that's another term I hate
Mhm.
as well because everybody has something that is a risk potentially. And so that because something serious can happen with every pregnancy, right? You guys, we know that sadly to be true that people cannot have anything on paper and then all of a sudden they do. So I really don't try to make somebody, I hope not, fearful that they are high risk, but I also try not to make somebody think that nothing bad could ever happen to them and their baby, because I think both ways is not maybe the best thing for patients, but high risk is a hard thing to find. I mean, I think, there's clear things like, oh, you had a prior kidney transplant, you're high risk. Your heart doesn't
Mhm.
work right, you're high risk. Everything else is just little parts that make you a special person, and we need to figure out how we give you the best care with those things. When it comes to the obvious guilt and blame, I'll get a lot where people say that they were very busy, they were trying to get everything ready for the baby, they weren't paying as much attention. And one of the things that, and it's always hard to find the right words for somebody who is blaming themselves, but I always talk about how that's kind of normal and that 99.9% of people who are working, taking care of other children, running around, doing things, this doesn't happen to their baby. So the
Yeah.
fact that you were doing all the things that 99 all these pregnant people are doing at the end of their pregnancies and this happened to you, it's not your fault. You're doing what so many people do and they don't have this tragedy. So it's not your fault that it happened.
I agree. And, there's some times you think, like, was I too stressed out at work and this and
Mhm.
that? Like, there are people having babies in war-torn nations and they're having babies still, unfortunately, in like such difficult situations. So, you cannot blame it on yourself, on your emotions. Like, you didn't love your baby enough, or you didn't,
Mhm.
whatever. Like, we always, obviously, we want to look for an answer. We want to blame someone. And sometimes that falls back on you when you don't get answers from your doctor, which is another issue, I think. And maybe that's a future episode with a pathologist. But we need to work harder on getting people answers as a cause of the death is so important, I think, for the grief journey as well as for your pregnancy after loss. If you have one, it's really good to know, what happened in the prior loss. Why did it happen medically speaking? Because there are reasons for stillbirths. It's the stillbirth is not the cause. It's just what happened. Your baby was born before um, or passed away before birth. So we need you to keep pressing forward. If you didn't get an autopsy done, there are ways to do things like placenta pathology after the fact. So go to our friends Measure the Placenta or on Push's page. We have resources there. There are definitely ways to find out information after if you didn't find it out from your provider or from the hospital staff. Because for myself, I was pushed out pretty much, not helped to find a cause. And that definitely made me internalize a lot of like, what did I do wrong? I must have not known something was different and I didn't do the right thing. So, now knowing the cause was the cord, it's been really helpful for me in my grief to be able to know, like, obviously I couldn't have known
Mhm.
the cord was being compressed. The doctors really didn't because they never checked the cord on especially low risk pregnancy. There's no scanning going on there. So, I mean, unfortunately, it was a very tragic incident that happened to us and our family. And, I do feel there's preventions for those kind of things now that like we really want everyone to be aware of. So that's why we're here to keep amplifying like fetal movement, kick counting, asking for more if you feel like something's wrong, staying there and getting more done for yourselves. And yeah, I mean, I'm still seeing comments being thrown in here about like, regardless of how hard you fight, it might still happen. So, you know, we can't unfortunately save every baby, but we're doing our very best. And I think that's, at least the parent should know like, we are all in this together. Even your provider. And sometimes it might seem they're very busy, and that might happen to you in certain groups where I know you're in a group as well, where you get kind of different people each time. But if you can try to establish more of a connection with your provider and really, let them know how you're feeling every time. And if you can request, to have the same provider, it may not be an option, but bringing in your support person. Any other tips you have last minute, Dr. Florescue?
Yeah, and part of why we do cycle people through is that our brains all work differently and we hope we'll catch somebody. I think you'd want to make sure that everybody in the practice is still listening to you, though, and that you have protocols. What happens when I have this? And as I said, it is gestational age specific, but that every time you call with a concern, you feel like you're taken seriously. And you sometimes can use, I know you guys like the mom words, saying, I don't feel like you're taking me seriously. I don't think you're understanding how worried I am. Sometimes you just have to use those terms, especially if it's part of a busy day and we're, doing lots of things. Just don't be afraid to like say, I'm really worried about this. What can we do to help reassure me? I think those words will make, I hope, 99.9% of OB providers' ears stand up and help them kind of get engaged. And even if that's a severe headache or you're feeling unwell, it's not just fetal movement.
There are a lot of warning signs, so pay attention to just how you're feeling as well. Um, I'll just put a quick plug in for Push. We have a Rainbow Clinic training. We call it a pregnancy after loss training. So if anyone is interested as a provider or a doula, a birth worker, anybody who's dealing with families after loss, you guys can take a training online, which is very quick. It's, I think, a few hours long, but you can take it at your own pace. It includes obviously parent voices, our experiences, because we are an organization that is founded by bereaved parents. None of us are employees. We're just doing this out of our heart. So we want to make sure future families have better care after loss. And you can go to pushpregnancy.org/rainbow-clinic, and you'll see all the options there. And if you need support too, if you're a parent, make sure that you go on there and check it out. You don't have to do this alone. There's a lot of great support groups out there. Griffin Cares is a partner of ours, and so is Chasing the Rainbows. So We also will be having within our change makers monthly calls just to kind of give each other support, because our organization, we're very much the advocacy group, and we all are like involved with, Shine for Autumn Act, the Stillbirth Prevention Act. We're trying to, pass legislative change and medical changes, but we still also need support because I'm telling you, I'm still traumatized, and this is 8 years later. So we definitely think that you should get help if you need it on this long journey. It's a long time to live without your child. Um, I know, Dr. Florescue, you feel very much about bereavement support, and that you have your book out now too for providers. Do you want to plug your book real quick? Because that's a great resource.
I have a bunch of them. So if any lost family would like me to send them to a provider, I'm trying to get people who want that. I can do it anonymously or in honor of your baby. And, we can get those to your providers. I'm also have a lecture that I can give about caring for lost families. And I am really happy to give that. Obviously we have to coordinate and everything, but I do think we really need to improve. If we improve the care that people get when they have lost a baby, that is going to make future doctors, especially, they're going to, if they see what loss means, then they're going to want to do everything they can to prevent it. So I see these as very well connected, because I think why prevention became such a huge thing for me 4.5 years ago is I had always walked the grief line with my patients. So when I heard about prevention and I heard I can maybe keep a grieving patient from happening in the first place, the two things made perfect sense. I think if we are not giving that great care during the time of bereavement, we may not be realizing the impact of the loss. So I do think one way of prevention is to teach providers, nurses, everybody involved on how to take the best care of people who've lost a baby.
Thank you. I appreciate that. I myself, I only have a certain amount of energy in a day, and I have my 3 children, Owen being my middle son. So my 2 living kids keep me so busy. So I focus my energy on the prevention, and like now I'm on the medical team here at Push. So I really thank any group that's doing support too, because unfortunately we are still going to experience loss in this country, and it's 21,000 babies a year right now. So that's a lot of families impacted, and they still are going to need support. And we will on our end keep pushing forward, trying to prevent it too, so we have fewer people with us here, because it's a trauma we wish on no one. And I know everyone here and the lives watching are just really thankful for everyone involved. So I just wanted to thank again Dr. Floresky for your time. And you're probably getting a call because she's such a busy doctor, so we're about to lose her, I think. But
No,
thank you all for watching,
did
and
you lose me?
I'll go to me full screen. There you go. So you can fix it. But appreciate everyone here. If you guys have any questions, feel free to DM us anytime. We are all volunteering again. So it's really what we do and love for our children as mothers and as family members that have experienced this tragedy. And we do have a lot of fathers with us here now as well. So, oh, she's back. So
I don't know where I
thank
went.
you again, Dr. Floresky, for your time. And we will have you back, I'm sure. Now that I've figured kind of how to use this thing, we're going to do it more. Every month we plan on having a new medical provider as well to answer questions from you, our audience. So feel free to send those in at any time, and we'll try to get someone to answer for you on a live. And then we will have some exciting things going on in February. So follow us on Push. If you're interested in the Rainbow Clinic training, I recommend hold on, because we're going to give a code out in February so you could take it for free. And that is not just for doctors. Like I said, it could be anyone who wants to support families after loss. Even if you're like myself, a parent advocate, you can go ahead and take that as well. So we would be happy to have that spread. We're calling it the Spread the Love campaign. So everyone can get better care after loss. So please take that and spread it to your community. If your doctor hasn't taken it, let them know. Please just take this for me. I really appreciate it. That way you can be more, aware of where I'm coming from, and it's just giving them that trauma informed, care angle of like what the experience is like for a parent after loss, because it's a completely different pregnancy. A lot and things have happened and you're so terrified. So it will be helpful for them as well to know how to help you through that process and have the better communication that you need. Any last thoughts, Dr. Florescue?
No, this was great.
This was fun, right?
I will
We're
come
like all the new tech.
anytime.
We're trying to get with it. Sam here, she's so great. Our executive director is commenting. So Oh, always free for last parents. So if you're a last parent and you want to take that clinic training too, if you're interested in seeing what it's like, feel free to DM us because we do have a code for last parents to take at any time. And we do have a lot of resources again on the website too. If you're pregnant now, whether you're a last parent or not, there's different sections. So you can take a look and see what you need there. And if you want to participate as a change maker at Push, we'd love to have you. Pushpregnancy.org/contact is where you can sign up so we can get you looped in on all our meetings and what we have going on. And we're kind of getting a big team together now for medical. We have a lot of things that we want to do this year. So we would love more support in all areas, whatever your interest is and whatever level of time you have to give so we can help improve outcomes and care for all families in the future. So thank you guys for watching.
Thank you so much.
We'll talk soon, Dr. Florescue.
That sounds good. Take
Bye.
care, everybody. Bye.